And there you go. Well, that's the sign. Great. Thank you so much, everyone, for joining us today on another session of Virtual Global Spine Conference. This is a special month for us because this month marks our 3-year anniversary. Believe it or not, everybody's 3 years older. This is our this month marks our 3 years. So a special big thank you to really everybody involved, co-hosts, panelists, folks that were with us in the beginning who are not with us anymore, the participants, the speakers, of course, the fellows, the students. I mean, just the list goes on. And in a couple of weeks, we'll have a separate special thank you kind of tweet to everybody. But today, I'm absolutely thrilled to be hosting Dr. Cara Sedney, who, very early on, she is in the Department of Neurosurgery at West Virginia University. I know, of course, Dr. Sedney through the AO Spine and through some other kind of programs that we've done together, but she really is a brilliant surgeon educator in my opinion, and in the opinion of many people. She sees a unique patient population. She's, obviously in it, which she will discuss, but she's in an area where there's a lot of spinal infections for the reasons that she's going to present. In fact, when I was honored enough to visit maybe 4 years ago now, 2019, as a visiting professor there, I think the residents showed me around the units that are dedicated to patients with PICC lines for IV antibiotics because they didn't have anywhere to go after. So it just was mind-blowing, kind of the care and really the selfless care that a lot of you guys do over there. So the topic, spinal infections. Dr. Sedney, thank you so much for joining us, and it's great to have you here.
Yeah, thanks for having me back to talk about these de novo spine infections. As with, Dr. Baj just mentioned, this is something that we and probably everyone else are seeing a lot of, but we see a ton in West Virginia. And really, just to set the stage, my only disclosure is that I love pus. I think infections are so fun. It's like really satisfying. And that's a really good thing because we see a lot of it. And the literature here is relatively nascent, although I did have a lot of fun going through it for this talk. So in many of the cases I'll present, I'm just as interested in what everybody else might do as in showing what we kind of have done. And there's a couple in particular that have been really tough that I would really love input on. So virtually all these came from patients that were done in the last month or that I saw in follow-up in my clinic in the last month. So for the students, how do infections get in the spine? Most are hematogenously spread through bacteremia with a systemic source someplace else in the body, although you can have contiguous spread, for instance, to the thoracic spine from a pleural infection. And we describe, bony involvement as being osteomyelitis, discal involvement as being discitis, and epidural abscesses, of course, are in the epidural space. It's a big problem as it can cause pain, spinal deformity, and neurologic compromise. And if it's missed, it's going to keep progressing. So these things are increasing in incidence probably everywhere, but definitely at WVU. The overall incidence, according to big databases, is nationally about 11 cases per 100,000 people, but it's much more frequent here in West Virginia, mostly related to the IV drug use crisis. You can see our institutional numbers here. I just pulled those from Epic, and there's been about a 3-fold increase from 2012 to 2020, and we currently see about 60 a month or 2 a day. And that seems accurate to me. I was on call one day this week, and had 2 cases, operated on one of those, and that's a very typical volume for every single day here at WVU. And immune deficiency and frequent vascular access are common risk factors that help sort of shape the 2 most common groups of patients getting these infections. There's a younger group with a pathology often driven by IV drug use. And then there's generally older patients with more chronic comorbidities and susceptibilities like diabetes, although you'll see in my cases, those two groups are starting to merge a little bit. And these are serious, situations. The risk of death in these is as high as 30%. There's a long treatment course, and this is very taxing on sort of the health system as a whole, because of how frequent they're needing antibiotics and the duration of that. As in any infection, you kind of need to know the causative organism to guide the treatment. The most common are gram-positive organisms and skin flora like MSSA and MRSA, although gram-negatives and multi-organism infections can be common in certain groups. Also in places outside the US, because I know this is a very international conference, there are entities we don't often think of in the US, like tuberculosis or brucellosis discitis osteomyelitis. I'm not going to talk about those because I don't have any personal experience with them. But in general, blood cultures need to be taken. A spinal culture should usually also be attempted if the patient isn't super sick. You might consider holding antibiotics until you get that to increase the yield. And there's a variety of methods described to increase the yield of a percutaneous sampling. You can use CT or fluoroguidance. You can even, an endoscopic sampling has been described. And of course, you can do an open biopsy if needed, which is obviously more invasive, but trades in higher likelihood of getting a positive sample. And then for percutaneous sampling, some recommendations to increase yield include using or targeting the paraspinal fluid collections if present, like a psoas abscess, using multiple core samples, or using large gauge needles. And patients will almost always present with pain. They may also have fevers, weakness, sepsis, that kind of thing, but pain is generally the first symptom. And because back or spinal pain is so common, it's frequently a misdiagnosis, at least around here. Patients often will come to the emergency room over and over again, especially if they are members of groups more likely to be stigmatized and have their pain minimized. And if people who might remember my last talk in this venue was about diagnosis-related stigma, which is something that I'm passionate about. So I'll just make a little brief plug that patients who use drugs or may be labeled as medication seekers or opioid seekers are actually rarely at this point coming to the emergency room because they want pain medication. They can actually buy much stronger stuff on the illicit market, and they expect you actually to say no when they ask. So they're not, not expecting that. In contrast, patients who feel that they will experience stigma in the healthcare setting will wait longer to present to the emergency room, even weeks after they become paralyzed from discitis in some instances, in my experience. So definitely please take pain seriously in the emergency setting, especially in people with predisposing factors like diabetes or IV drug use or end-stage renal disease, that kind of thing. So the cornerstone of treatment for infection is obviously antibiotics, but the traditional dogma of 6 weeks of IV antibiotics is kind of being shifting. Both our center and other centers around the country have been shifting towards 2 to 4 weeks of IV antibiotics, and then switching to the rest of the 6-week period being oral, assuming you have adequate sensitivities to the bug. And that's a really great thing, is it lets patients get out of the hospital early, particularly in our rural areas where home health is difficult to access or manage a PIC, or in situations where patients aren't able to be discharged with PIC lines. And we've had a really good experience with this early on, and you can stay tuned for further reports from that on the medical ID side. This is a poster that our medical ID team presented about COPAD, which is complex oral antibiotic treatment. So when do we actually need to operate? There's, I like good scale, and there's been some nice work from an international group based in Europe and North America to try to figure this out. This early scoring system tries to pin down who needs surgery and who can be treated with antibiotics. And this scoring system is new. It's not, totally validated yet. And I'll point out that it works a little bit different than some other scoring systems, in that the lower the score, the worse it is, more likely that the patient needs surgery. So this is definitely something to play around with and watch as the literature develops on this scoring system. Patients who have acute neurologic dysfunction go to surgery regardless of anything else, obviously. And otherwise, the more severe the neurologic dysfunction, the less points they get. They also get less points for mobile or junctional spinal location, canal stenosis, mechanical pain, and certain comorbidities like IV drug use or diabetes. It's kind of similar to scores for, for instance, spinal tumors. So one point that I think is important to make is that a lot of these findings detailed in this score are very early findings. Like these radiographic findings are exceptionally early. And like I will not almost ever see a patient that has like such mild findings in their discitis. And similarly, it's also really unusual to not have pain, like no pain is on here, very rare. So anyway, this is a really interesting rating system trying to address who needs surgery, but not necessarily like what surgery needs to be done. So as we look into some cases, this unfortunately won't give us a lot of guidance on that. So with that, I will present a case. This is, just sort of a very average everyday case that we see at least. This is an 80-something-year-old guy who presented with an infected prosthetic knee, pneumonia, sepsis, and this, thoracolumbar ventral epidural abscess that your radiology very helpfully measured for us. And then T11 to L1, discitis, osteomyelitis, and a pretty significant cardiac history. And we have this MRI that was obtained because of where his location of pain is, but he's too sick to get uprights or anything like that. So just, I guess, open that up to the floor. Sorry, just seeing some of the comments. I do love pus. Just curious how everyone would sort of approach this case.
Yeah, let's get some buy-in here from the audience and the participants. So 80 something year old male obviously has this epidural abscess, some osteo. The question obviously is, first things first, is he neurologically intact or does he have deficits from this?
He's intact. This stuff is sort of conus level, but he is primarily intact as best we can tell. He's really sore in that prosthetic knee. So there's, probably some pain limited weakness of that knee. Okay,
got it. Well, I will ask one of my co-hosts who I see here today, Nader, Dr. Dadale Galgano. Nader, what do you think? You want to take this one?
I think to be honest, I mean, I'll definitely look at closer, definitely there's a lot of stenosis. There's a collection there. Now, to me, to be honest, it's just those patients are really sick. And the threshold to operate for me is a neurological deficit versus instability. So really, in this particular instance, I would certainly want to make sure that the patient's neurological exam is intact, and then and if that's the case, then we need to find an organism. There definitely needs blood cultures, and if we can make the diagnosis with blood cultures, then we can treat it with antibiotics and aggressively. A close follow-up in terms of daily, daily or like maybe Q 4 hours neurological exam, just to make sure that the patient does not deteriorate neurologically. If the patient has a deficit, certainly the answer is easy. You gotta do a laminotomy and get to the abscess and evacuate it. But 80 comorbidities, I'm not sure if the patient's on a blood thinner or not blood thinner. So if the patient's intact and we have an organism,
he's on Eliquis.
He's on Eliquis. So
yeah,
certainly that's the more we talk about the patient, the less I want to operate on him. So so if the patient is intact, certainly. So if we have an organism growing, then certainly, and we have then we can treat this successfully with antibiotics.
Hey, this brings up a good point that I was going to wait till later to ask you, Cara, but I'm going to ask you this right now because I think this is potentially relevant. Let's say patients like this who you think from a surgical perspective, they're neurologically intact, they've just identified an organism, you really want them to start antibiotics, maybe try it for 2 to 3 weeks, repeat imaging, and then you get that very, very common phone call from ID saying they want source control. How do you answer that question? How do you answer the "we need source control" question that seems to haunt us here on the neurosurgical service?
Yeah, so that's an excellent question. I'll sort of address that a little bit, but I think that I buy into the source control thing. I'll show you some slides about sort of multidisciplinary surgical discussions, and that in those multidisciplinary discussions, we might operate more frequently, but the surgeries we do are less invasive. And so, for someone like this who had blood cultures, but it's not yet growing anything, I'll just come right out and say we evacuated that epidural abscess. Like we didn't evaluate for instability. We will do that later. But getting source control, getting a bug, and someone who's like actively kind of being septic. Now he is on Eliquis and all that sort of thing. So we did sort of definitely a less is more kind of approach to it. It might not be the end of it for him. Obviously I would like to have uprights and things like that to see what those sort of split open disc spaces do. But for now,
How do we know what the source is? How do we know if the source is the knee? Is it the blood? Is it the back, the spine? How do you know which is the actual source for source control?
Well, I think the problem is that any collection of pus can be the source, right? Or can become a source later. So he's got this infected prosthetic knee that definitely needs out, needs an antibiotic spacer. But the concern is that if you do that and leave these other things, is that going to become a source and reinfect that joint? You know what I mean? And this is a serious issue, particularly with endocarditis, which I'm also going to talk about here in a second. But that, having that sort of rapid like eradication of all of those sources is really important. And so it doesn't always have to be us, right? Like I'll pretty frequently say, all right, have IR put a drain in that psoas abscess. Like I don't have to go take care of that. But taking care of these things, if they're, a little on the bigger side, like this was decent size and I didn't get a crap ton of pus out of there. You know what I mean? But definitely, there was some stuff in there. We were able to get into the disc space, and we just did that through like I agree with Dr. Baj, like tubular lambies good. We just did a right-sided ligament sparing laminotomy, went into the disc space, passed, a wood cent around the ventral dura and washed that stuff out with like, saline irrigation. So I will keep moving then. So the way we've kind of conceptualized treatment of these patients is to kind of separate out those most urgent components of like source control, and then the addressing like these large abscesses or large collections, and then also addressing neurologic protection. I worry because this is conus level, and so you worry about the venous thrombophlebitis sort of mechanisms of epidural compression. And so we try to rapidly address this either through IR drainage, like psoas abscesses, or evacuation of epidural abscesses, and then follow later to see if they have instability or failure of medical treatment. And obviously, if it's grossly unstable, that's not the same scenario. But addressing all of it up front seemed like it would be like a huge, invasive procedure for this old guy on Eliquis. And so we basically just went into the disc space and evacuated the ventral collection. And that may be all we have to ever do for this guy, following with his, CRP X-ray clinical picture, and obviously making sure that we don't get instability there. And yeah, that's an MRI. That's a contrasted MRI. Phlegmon is a difficult thing. Sometimes you can't really tell what is phlegmon and what is abscess. At least I can't. And so sometimes you get in there and have less satisfactory stuff. But when they're really floridly sick like this, it's usually an acute thing with liquid pus. And then this patient's infected joint begs that question, like in complex infections, what do you operate on first? Like, does it matter? And these patients can have multiple co-infections such as endocarditis and septic arthritis like this guy. And again, another group also out of Europe has really tried to define how to go about deciding this, at least for the endocarditis side of things. And of course, the reason that this matters is that if all the areas of infection aren't addressed adequately or discovered, then you end up reinfecting your hardware or prosthetic devices that you put in because of infection. And that's a super feared complication of things like heart valves because of the difficulty of redos in that scenario. And we've also had people with recurrent reinfections of spinal hardware from their joint replacement and vice versa. And that's a really difficult thing to get a handle on. So you can see in this sort of protocol that they've developed, if someone comes in with suspected discitis, they have a really aggressive, and I guess it's kind of hard to see, but a really aggressive approach for searching out infection anywhere else in the body, looking for endocarditis, aspirating any prosthetic joint to see if there's infection there, to the, and to that extent of really looking for any possible areas of infection. And then over here, you can see for patients that have like a a really urgent cardiac surgery need, they'll do urgent cardiac surgery, and then right after that debride the spine as soon as possible to prevent reinfection of the valve. So it's super complicated in terms of even just the timing for these patients. But in the case that we presented, we did the epidural abscess the day before we explanted the knee prosthesis, and he was on antibiotics, for 24 hours before that was done. So here's another one. This case is, again, we kind of focus on the epidural abscess component for source control. Here's this case. This is a 49-year-old female with IV drug use who presented with severe sepsis and multiple medical complications of that. She was, intubated, sedated due to severe ETOH withdrawal. And so she was having DTs. So we didn't have any exam on her. This was basically just obtained as part of a extensive workup, trying to figure out why she was septic. So what do y'all think about this?
Yeah, let's get some more participation here from our audience. See what you think. Put your answer in the chat. Yeah, I think this is to me. I'll take this case. To me, this is probably a little bit more surgical than the last one. She's symptomatic. She's got a large collection there. She's young. It's I would probably be going into surgery a little bit. I would have a very low threshold to take this patient to surgery. The sepsis thing, or the severe sepsis, is kind of, I think, important because, right, this happens all the time. It's, well, you don't want to take a patient who's hemodynamically unstable to the OR, right? Anesthesia won't like it, but they may not stabilize and they may not improve their sepsis unless you take them to the OR. So it's like, you just optimize them and you do your best. And as long as they're not on like 3 pressors, you kind of have to go and do it. But for me, this is probably a surgical case. And like I said, I think in my previous thing, I would say I would probably try to do this less invasively with a tube and just try to wash things out that way.
Yeah, I feel like a tube is really just like a retractor, so I don't really usually use tubes. But yeah, we just did like a little minimally invasive laminotomy, used a catheter-based irrigation. And I mean, honestly, this case took like, 30 minutes. It was super satisfying because that pus just like squirts out of there. She also had really big paraspinal abscesses that we got on the way in. It was very, very easy to do. I totally agree that's in fact kind of what we did. Yeah, and there's no way to do an exam, as Dr. Terry said, because she was like heavily sedated because of her DTs. Here's another one. So they just keep coming, So this is a 53-year-old male also with IV drug use, and he's got this epidural abscess from T4 down to S1. What's everybody think about that?
What do you think, Nader? Do you want to?
Yeah, absolutely. I mean, this is probably, to me, I mean, it's interesting cases like the previous one, I'm not sure, like I get it. It's a big abscess and it's causing caudal aquina compression, but patient is intubated for DTs. So I'm not sure if I want to, yeah, it's a tough decision, right? Like I don't have an exam. I don't know if, like I don't really like taking patients who are like intubated and having an ongoing issue and then add surgery to it, right? Like, that's an ongoing active issue. The patient has DTs and I'm exposing them to an operation. I usually would wait and get it stabilized and then do it. But yeah, it's interesting. I mean, certainly Dr. Sedney has 10x experience than me. This one is probably the easiest easiest one in my opinion. You can do laminotomies at the thickest areas they don't have to unzip it from T4 to the sacrum. I think you can just choose the thickest areas of abscesses and kind of usually these should kind of like easy to irrigate out, like with maybe laminotomies every other level at the level of the thickest abscesses. And certainly I think down in the sacrum here, L5, S1, that's the thickest there. So maybe I'll do laminotomy there too, but I don't have to really do a laminotomy all the way contiguously. A laminectomy from top to bottom, I don't think that's necessary, but that's certainly surgical.
Yeah, so that's what we thought too. And so he was actually neurologically intact, but a lot of pain. But again, worry about that the venous thrombophlebitis mechanism of cord infarct. And so we did so instead of doing skip lambies, we did what's called apical lambies. So we did a laminotomy at T5, one at T10, and then one at L5, and did catheter irrigation. So I'll show you what I mean by that here in a bit once we get through this couple stretch of epidural abscess cases, and that worked really good. How about this one? So they keep coming. So 57-year-old man, this guy has end-stage renal disease. He presents with quadriplegia, and you can see this sort of extensive like ventral epidural abscess. What does everybody think about this one?
Yeah, I mean, do you want to take a crack at it, Ali, or you want to?
Yeah, please. No, keep going.
Is this too many cases? Sorry.
No, that's great. So I know it's a ventral abscess. I'm not gonna, I think the goal is here is certainly to identify an organism, hopefully with a blood culture, but certainly this is very concerning. Patients, significant deficit quadriplegic. I would certainly do a laminectomy from C2 down to C2, 3, 4, 5, 6, 7 to C7 and diffusion. That's what I would do. You can say, okay, I'm not going to fuse right now and come back later, or you can do it up front. I'll do it up front, to be honest, but I'll do a laminectomy to decompress the spinal cord, right? Like it's not to evacuate the abscess as much as that to give room around the spinal cord dorsally. But certainly, I don't think an anterior approach for this is, in my hands, is reasonable. It's too extensive for an anterior approach. I would certainly approach this posteriorly. I would do a C2 to T2 fusion probably, and the laminectomy from, bottom of C, or like C2 to C7. That's what I would do.
Gotcha. So, I am with Doctors Burchuk and Hashmi. So I personally have a lot of trouble getting this out from posterior. And to your point, it decompresses the cord, but at the same time, it doesn't really do the source control and that sort of thing. So what I in fact did do in this one was an ACDF. And so I try to figure out, like, a lot of the times that pus will sort of accumulate up here at the top, because there's like more potential space there, I guess, because the canal's wider. But I'll try to figure out which disc it came from and go there, because it should be contiguous all the way. And so I targeted this disc here, did an ACDF, and then we'll take, like, I can't get the red rubber catheters or the NG tubes like in this space, but what I'll do is take like a needle tip irrigation, bend it 90 degrees with like a hemostat or something and push it in there and irrigate that way. And the reason I put this case is because we don't normally do like follow-up MRIs, but we did on this guy. And you can actually see that it's like it eventually went away. You know what I mean? And he had pretty good improvement actually of his quadriplegia. So it had a good neurologic improvement. The one thing I'll say though is actually I'll wait. I'll tell you that in a different in the next case. So that's what we did for that, and that tends to be my my way of doing it with that. And if you don't feel like you get a lot of stuff out, then you got to be prepared to do a corpectomy to get more out. But vast majority of the time, an ACDF is good enough in my experience.
How soon was that MR, Cara, after the index surgery? Is that like?
This was like 2 months.
Mm-hmm.
So it wasn't like right afterwards. It was done for assessing adequacy of like infection treatment.
Okay.
Hey, Cara.
Yeah.
Mike, can I ask you a quick question?
Yeah.
So I've always been in a conundrum after you operate on these patients, or even before. What do you do as far as mean arterial pressure goals for them? Do you treat them like a spinal cord injury? The reason I'm asking is because obviously the mechanism of their spinal cord injury is the fact that they have venous congestion. And I've always had some concerns that if you push their MAPs and you try to get them above 85 or 90, are you just congesting the spinal cord more? Because now you're maximizing cord perfusion, but if they have venous thrombophlebitis and they're having outflow issues with the spinal cord, blood flow and whatnot, are you making the process work by pushing their MAP? So I'm curious how you manage them after surgery.
That's a great question. I honestly, like, you put more like elegant thought into it than I normally do. And that the reason for that is probably just because often when they present, it's not like I'm getting them like right when it happens. You know what I mean? So I'm very concerned about treating them like spinal cord injuries, but more just like preventative stuff, like preventing decubes rather than maybe doing mat pushes. But I guess I hadn't really thought about the pathophysiology. We don't generally do mat pushes for these. So.
Yeah, I mean, I typically do, but I don't know if it's the right thing to do. Ali or not, you guys do mat pushes for 5 to 7 days if these patients present with a significant neurological deficit?
Oh, absolutely. Absolutely. I'm actually sometimes comfortable giving them a little bit of steroids too. Not per the spinal cord injury protocol, but I'm trying, to decrease swelling, improve cord perfusion, and decrease cord edema. So I'll give them a little bit of dexamethasone, and also certainly keep their maps up for a few days in the unit, and then ensure that when we wean off the inotropes, they're holding up their maps reasonably.
Yeah, that's a good question, Michael. I think, to be frank with you, I never really thought about it as like you said, the same mechanism. I probably don't actually necessarily press these patients. I'm okay with steroids. And I think you're right. I think just for me, I think the mechanism has always been like more of a sudden or instant septic thrombophlebitis, or there's some kind of acute mechanism in which they have infarction of their vessels as opposed to a mechanical. For me, I think that yes, some cord compression, of course, is mechanical, but I feel like a lot of these patients develop acute changes due to actual, infection in the vessels that feed the spinal cord. But I don't know. Maybe I shouldn't. Maybe I should actually treat these like our acute spinal cord and push their maps up. I don't know the answer to that. Just a quick question, Dr. Sedney, for you, and I see Nader here try to answer it. Do you think, in your opinion, patients who obviously need hardware, whether ACDF or posterior instrumentation, are they necessarily, do they must they have long-term antibiotics or PO antibiotics, so chronic suppressant therapy, or does it depend on the actual organism?
Yeah, that's a good question. I will admit that I generally defer that question to ID, but I think that unless there's some specific organism related concerns, they might do oral suppressives for some amount of time. But in general, like, it's pretty well characterized that you can use spinal hardware in spinal infection and not have issues with reinfection. And then in response to the question about autograft for ACDF, I don't think you need to go to that effort, because this 100% will fuse. Infections fuse very well. And so I don't worry about, that's not something that I worry about. I worry about other stuff. So with that in mind, I'll show you a very similar case. So this is a 49-year-old with IV drug use, presented with quadriplegia, found down, similar stuff. He has some posterior stuff. He has a lot of this anterior stuff. So I don't know that we necessarily have to like ask around on this one. I'll just sort of show this because I wanted to bring this one up because it illustrates a problem that I've noted commonly with this like way that we deal with these, is that you'll see that his post-op imaging looks fine, but then he actually healed up, did fine. I think we actually did like a lumbar abscess later in him for source control, but then 2 years later, you can see he fused in kyphosis, and that's like super duper common. So I just sort of bring that up. Like, I think it's well known that for corpectomies, you can get that in these, but even like in an ACDF and like this guy, I don't even necessarily see any bony involvement here, but still ended up fusing in kyphosis. So just a interesting comment or finding in that. And so in some of these people, I almost wonder if I need to follow them and fuse them posteriorly before I let them leave the hospital. I don't know if anybody has thoughts on that.
Yeah, I think that's the problem, is that a lot of times you lose follow-up on these patients, and yeah, if you detected a little bit of kyphosis or some hardware issues, you probably would have a very low threshold to bring them back and back them up posteriorly. You know, these cases are difficult. I would say that, and I think and I'm sure you're going to show cases like that, but you know, I am a big believer of the posterior long construct approach for these. Not because they necessarily need it in every case, but you're treating their psychosocial issues and the fact that they may not come back. So maybe going bigger on them up front, it may be the better thing. But
yeah, I kind of agree with that because of this. I still like going anterior, but I think maybe backing it up posterior, even just for an ACDF. It seems like overkill, but I don't think that it may not be. So anyway, when, you know, in summary, kind of when dealing with epidural abscesses, I think it's important to, you know, consider pathophysiology here, because you want to achieve both infection control and neuroprotection. So if it's cord level, you got to be worried about that septic thrombophlebitis, and be more aggressive in the cervical and thoracic region. I think it's probably beneficial to go where the pus is, and then, you know, things that might make you say, oh, this epidural abscess needs surgery would be things like, you know, infection control issues, like, you know, having diabetes, like in the site score, higher CRP, white count, persistently positive blood cultures, and that sort of thing. And when you're dealing with this, kind of like what we talked about for most of these epidural abscesses, like a more minimalist approach is I think ideal. And what does that look like? Well, you know, you don't have to necessarily decompress every single affected level. There's a lot of case reports and small series about the various techniques that you can do to get pus out of the spine. But some version of like a skip lammy or ligament sparing laminotomy is enough, especially if you can pair it with this catheter-based irrigation. And again, this is something that is actually well characterized in the literature, but it's only like a bunch of case reports or small series, but it is really well characterized. And you can combine that catheter irrigation with a single lammy or apical lammies, or, you know, it's even been described to use radiographic or radiopaque dye to see, make sure that you're getting all the areas, and you can use different kind of devices. This was as a WVU plug. Reggie Haid wrote this up back in 2001. So this is definitely not a new technique. And then this is just a picture of that pediatric NG tube, which is my favorite way of doing that. This is from an article out of the Brigham. And if you do apical lammies, you can use this 3 or 4 French pediatric NG tube, attach it to saline syringe, and you just put it in the gutters, you put it in the middle, and you irrigate it out. And if you can put it in one incision and see it come out the other incision, you know, you have a pretty good washout without needing like any kind of dye or anything like that. Intradural pus. I'm actually going to get to that. There's I have a case to show. It's more frequent now than we've ever seen it before. We have like 5 or 7 cases in the past year of seemingly intradural infection. But I don't necessarily think I would use this technique for intradural, just epidural. And then, as we kind of talked about, one special case where maybe a minimally invasive approach isn't always work is that ventral cervical abscesses. It's almost impossible for me, at least, to access that dorsally. And so I go ventrally. The patients are really sick, and, you know, you worry about even turning them prone. So we do an ACDF. It's really serviceable. It's fast. If we get a good amount, we don't have to do a corpectomy. If we don't, we have to be prepared for one. But always consider that progressive kyphosis. So I'm sort of moving back towards circumferential fusion. There's a nice paper about that from 2015, but I think it's more in the context of corpectomies, but maybe even in ACDFs that's needed. And so, you know, you can see some of the different things that other groups do, like even as much as a non-instrumented fusion or really maximal. Like I'd be very nervous doing this and not backing it up though. And then some interesting techniques that I came across in like reviewing the literature for this talk. This is a picture of an interesting sort of multi-segment trough that gets drilled sort of mid-vertebral body all the way along the length of the abscess, and then evacuating or removing the PLL and evacuating the abscess. It's very interesting. They don't have any follow-up radiographs, but it would be interesting to hear from anybody if anybody's ever done that. and then a posterior approach where you drill out the pedicle. And that's also kind of interesting. They have to also fuse them. So, it'd be interesting to see if anybody uses those with good success. I kind of feel like an ACDF is kind of fast and easy with the exception of that kyphosis problem. So that's probably what I'll continue to do. But if anybody else does something different, let me know. I'd love to hear about it. And so here's another one. So this is a 62-year-old guy. He had L4, L5 discitis, had an evacuation of an epidural abscess at an outside facility that was Klebsiella, was gram-negative, had a full 6 weeks of antibiotics, and then had continued evidence of infection after surgery. And you can see the fluid in the disc space here, and you can see his uprates here. Any thoughts on this one?
Mike, are you still there? Dr. Galgano? Yeah, I know he's coming in and out, but see what his thoughts on this case. All right, we'll get him on the next one. Yeah, I'm happy to take this. Also happy to see if any of the participants have any thoughts on this. So let's see, discitis, status post, evacuation of SEA. Yeah, that's interesting. So that's literally at the disc space there at L4-5, and I think I'm probably, my own personal experience is I'm probably a little bit quicker to operate on obviously symptomatic epidural abscesses, epidural lesions versus necessarily just infection within the disc. I think my indications, and correct me if I'm wrong, it's, I really have to see significant progression despite IV antibiotics to actually treat discitis. But what I've done in the past is I've gone, basically like a MIS discectomy approach where I'll go and access the disc and get a curette and just curette the disc, get cultures, and not necessarily, although it's okay, but not necessarily put in like obviously a cage or anything like that. I tend to go in and just debride that disc space with a curette. And, the several times that I've done that, I felt like that was okay.
Yeah, I think that probably would work. Like this guy, so he had definitely failed 6 weeks of treatment with continued pain indicators and CRP and stuff like that. So I definitely think he needed something. Infection fuse. So like maybe fusion is over treating it. But it seemed like there was a fair amount of movement there. What I did was just sort of like a TLIF approach and just did the disc stuff there and put in like a big TLIF graft. I see Dr. Burchak talks about an ALIF and perk screws. I'll talk about why I don't like ALIF for these in a couple cases from now. But for me, like even if you use a really big TLIF graft and just get it, you have to, it's a little challenging because the end plates are kind of undulating from the infection. But if you can get it right into the right spot, I don't know, I kind of like that. And so this guy's really recently post-op, so he's kind of wonky x-rays. He's not totally upright, but that's kind of what we did with that one. How about this one?
Can you go back to the previous? So, Cara,
yeah.
My philosophy with these, like first, if someone is not getting better on antibiotics, then I always want to rule out that it's not a situation where we missed the correct organism. So I would want to definitely reculture, maybe resample, because if it's a different organism or multiple organisms, let's say, I want to certainly tweak the antibiotics, change them, because that's always like because my understanding is if you have the correct organism, antibiotics should take care of it. If it's an aggressive infection, then maybe multiple antibiotics or something like that. But that's always, I want to rule that out. Like, okay, the CRP is not trending down, or they trended down a little bit, then they're going up. There's something wrong. First thing I want to ensure beyond source control is do we have the correct organism? Are we using the correct antibiotics?
Yeah, and I agree with that. I definitely think that that's how it was handled when I was in training. And it was like, oh, give up, another antibiotics, more antibiotics, more antibiotics. I can tell you that the complications of the antibiotics themselves are not insignificant. So doing like 2, 3, 4, 6 week courses is not without its own morbidity. And the other thing is, you know, when I do these, I always take cultures, and very rarely is it a second bug, although you certainly could do that. I think if there's no bug, then maybe trying harder to get one is valid. But if we have like a well-characterized organism, and we don't have evidence of, like, this guy was not an IV drug user, was not like doing re-injecting, reinfecting. There's definitely a scenario of that in certain patient populations. It seemed to us, you know, very much like a failure of medical treatment. So I will show this one. So this is a 67-year-old guy who had fevers and back pain, also incidentally frank cervical myelopathy, which was also dealt with. But what does everybody think about this one?
What are your thoughts, Nader, on
Yeah, I mean, back pain. I mean, this is causing instability and kyphosis, so that's an indication for surgery, in my opinion. Now, what to do? We can do multiple things, but so this is 5, 4, 3. Is that 2, 1, 2, L1, L2? Am I right? 5,
Yeah,
4.
1, 2.
Yeah, 1, 2. So you can see on the MR the patient corrects. So probably when you put him prone, he's going to correct easily. So I'll go long segment, decompression infusion, get into the disc a little bit, you know, wash it out. But I won't put any necessarily, you know, if there's room to put a cage, I'll put. If there isn't, I'll just, you know, I'll probably put BMP in there, in that gap. And with a long segment fixation, he 2 up, 2 down, let's say 3 to 4, 3. So 1, 2, so 11, 12, down to 4, 11 to 4, posterior fusion, decompression, get into the disc, put some BMP in there, wash it out, and that's what I would do.
Cool. Yeah, I agree. There's a lot of ways to handle this, and definitely there's you know, all this fluid in here is like just a huge potential space. You can see it closed down here, and you can see like this sort of like is a key that fits into this, and so you know what's going on in there. I will say that every time I don't do something in the front with these big gaps like that, I always regret it. Always. And like something big like this, I wouldn't like. That's obviously not something that you can do through like a Alift approach, or at least I can, especially because there's this big rim of bone posteriorly, and then you're going to be in this huge hole. So this is what we did. And again, this is a relatively fresh post-op, so this is just his first set of imaging. Antibiotic seeds and vertebral defects, that was a question. I personally don't. I will say I love Vanc powder. I put that in everything, but so
I was just about to put that in the chat. Do you use Vanc powder or not? So I'm glad you.
Oh, I love it. Everything. Yeah, so that's what we did with this guy. Is a little bit different than the first one. But like I said, anytime I don't try to do anterior support with a big gap like that, I always regret it. And then I'm always like, okay, I have screws pulling out and I have to like go even longer, and it's just a pain. So anyway, that's my hard learning there.
Cara, quick question. So
yeah.
like with an acute infection, aren't you worried like with the like thoraco-abdominal approach, like vascular, like things are stuck, and what's your experience? So because like, let's say you said you avoid an Alift probably because of the inflammation of the vessels in the front. With an anterolateral approach, that's not as much of a concern, correct?
I don't think so. I mean, I do for these, and that was a relatively acute infection, particularly for the chronic infections. But honestly, like almost, you know, I would be liberal in using an approach surgeon on that, because I don't want to be left holding the, you know, whatever horrible thing that I just did. So I'm in the minority on that. Like some of my partners will do the approaches themselves. So, you know, yeah. So discitis, osteomyelitis is a little bit different. Like you're worried about instability or persistent infection to really prompt a surgery. I don't think you need to just go operate on all of those. And that can be done a bit later than stuff that's done for pure infection control reasons, except for like, you know, gross instability and that kind of thing. I personally, again, try to do circumferential fusion with anterior debridement and reconstruction. I always regret it if I don't. But not everyone needs a fusion, although a lot of patients need a fusion. There was one study that found only about a 3% conversion rate to needing a fusion after a decompression, but in those set of patients, 2/3 of those patients were just fused initially. So probably depends also about, how advanced these things are on presentation, because you'll notice like the last case I showed does not look anything like those, the radiographic findings on the site score, for instance. And then one of the key things after that, initial sort of presentation with spinal infection is to follow them. And so treatment indicators can be negative blood cultures. If you have a persistently positive blood culture, you're missing something somewhere and you need to look again. Also following the CRP, you want to follow that trend. And if there's an early decrease, that might be helpful. We follow that even on the outpatient basis, the CRP. And one thing I can tell you is that it is definitely nonspecific. And the most common reason that we get a bump in the CRP in the outpatient setting is a new DVT. It's not actually infection recurrence. So here's one that sort of came in the outpatient setting. It's a 51-year-old guy with a history of IV drug use who had recurrent osteodyssitis. Okay, and this illustrates that scenario of like, do you have the right bug when you have recurrent exposures to new possible infection? So he initially had L2-3 discitis. That was MRSA. That was treated. Then he presented again with T9-10 discitis. He still had like the residual evidence of the L2, L3 discitis as well. So we biopsied the new one. That was MSSA. That was treated. Then he had a recurrence of the pain. It was clearly in the, thoracolumbar sort of junction, and not in the lower lumbar area, and increasing lab markers. So, what does everybody think about this one? And this is his imaging after treatment and the X-ray at the end of treatment.
Yeah, I'm happy to jump in on this one. I mean, I think he obviously shows a focal kyphosis there between the supine and then the upright films. He's got destruction there, I guess maybe mid or a little bit lower thoracic spine. So, that's an area that's hard to treat, and it's prone to progressive deformity. So I'd have a low threshold on doing a posterior decompression, try to get maybe like a transpedicular approach, try to get into that ventral stuff. This doesn't bother me like the last case in terms of necessarily needing a corpectomy, but, I don't think it's wrong to do that, but I would probably do all posterior transpedicular for some ventral debridement and a long segment construct.
Yeah, that's kind of what I did. And I tell the residents that this doesn't have to be like a corpectomy with a capital C. Like all you have to do, like I like the transpedicular route and you take the nerve root and things like that, but you just got to make a hole and then you got to fill it with something. You know what I mean? Is kind of what I think. In reference to the suggestion to let him autofuse, I mean, I guess the concern is that it seems like it was active infection because he was having increasing lab markers and recurrence of pain. So this one did not seem like just an instability problem. It seemed like an infection problem. And so that's what we did. And it doesn't have to be like a huge corpectomy or anything, but again, just like make a hole and fill it and get some stuff out for some sample and things. And so this guy illustrates really some of the impacts of this IV drug use on the patients and how they do. These patients present later, they have more significant disease, like this person you can see here who left AMA, came months later and looked even worse. And the reason that they leave often is because their pain control is inadequate. They're having withdrawal symptoms that are not addressed. And that will create what's called a patient-directed discharge, which is kind of the new term for against medical advice discharge. And the majority of those patients will present again with incompletely treated spinal infection. So it doesn't really fix the problem that they have left. They also can commonly have reinfection from a new exposure from any kind of needle in the skin. And so actually I do a lot of like sort of harm reduction counseling with these patients, like in terms of saying, you might think that not reusing needles is keeping you from getting infections. And yeah, that'll keep you from getting hepatitis, but any kind of non-sterile technique can give you a bacterial infection. And then follow-up is important. We continue to follow patients for at least 2 to 4 weeks after cessation of antibiotics to make sure that that bump in that lab doesn't happen. We follow x-rays, avoid MRI unless it's clinically needed because it's always going to look awful. And sometimes we'll use advanced nuclear imaging, particularly in cases of people that have like infections in the setting of previous surgery. And multidisciplinary care is really key in this. So there some good paper from Germany, I believe, with some multidisciplinary infections conference that includes a bunch of different people. And I think I mentioned this before, it demonstrated decreased total antibiotic days, more frequent surgery, but less extensive surgery than if the surgeon themselves made the determination. And as an extension of that, we have even more extensive multidisciplinary care for IV drug use patients. We do wraparound services with psych, pain, care management, et cetera, and have like a specific medical service just for these patients, but it doesn't match the demand. We can't get them all onto that service. So here's a couple more cases. We can stop whenever y'all need to. So this is a 58-year-old guy with diabetes who had spinal osteomyelitis. It was MRSA from positive blood cultures, treated with a full course of antibiotics, and then had worsening neck pain, but he was afebrile and downtrending labs. And we'd had no original MRI because the patient just was refusing. So this is his original CAT scan. Okay. Then we saw him in clinic, convinced him to get an MRI, found this. So how would you deal with that in a patient with like essentially normal inflammatory labs, but increasing pain?
Well, yeah, this is probably, this is probably one of the tougher ones in terms of decision making, right? So they're intact. Their inflammation markers are normal or normalizing.
They're normalizing, yeah.
And and then is he still having pain?
Yeah, increasing pain.
Got it. Yeah, I mean, boy, I'm not gonna lie to you. I may use Dr. Burchuk's technique here of put him in a brace and let him autofuse. I have a feeling he's not going to do that because he's, obviously, going to basically have a cervical thoracic deformity here any second.
Yeah, and I feel like he kind of does. Like, I mean, you can't really see it, I guess, on this picture, but I feel like in the upright X-ray, he's got some kyphosis there at the junction.
He does. Yeah, one thing that I was going to mention earlier, and I think it applies to this case, and I don't know I really do not know what the pathophysiology is, but I've always known, and I think you agree with this, is that instrumentation and stability expedites healing of infection. I just don't know why that is, but it just does. You create that stable environment, and antibiotics seem to just work better. So this is somebody that I think if I were going to operate, I would do a long posterior construct, some kind of long multi-level cervical thoracic construct on him. Maybe hold off going from the front just yet.
Yeah, that's exactly what I did. So, because the idea was that you can see on the MRI, he's got that sort of like that disc gap that looks like the other vertebral body fits into, and that kind of goes along with the alignment and upright. So I didn't think it was necessarily going to heal on its own because it hadn't fused. So we didn't do any anterior debridement, just did posterior stabilization, considering that it wasn't an infection control surgery. It was just stabilization, and definitely like ACDF would be reasonable. I think that is like C7T1. I didn't think I could really get down there. So I just did long segment posterior. And this is my like PSA about an Alift approach in infection. So this is not, I did not put all this stuff in here. But this patient came to me with this, a 5-1 discitis, gram negative, that infectious disease had been treating for a year with antibiotics that couldn't get it treated. And you can't really tell, but like the iliac bolts are sort of hollowed out and things like that. And I don't know how she ended up with all of this. You can see she had a PSO at some point, probably started out with like myelopathy or something like that. And so my plan at this time was to go from an Alift approach, like fill the hole with something and then turn her on the, posterior and redo the posterior hardware. And like, it was just, enormously difficult to approach that because the veins were plastered down on top of the gap of the disc, and so you ended up with like a hole this big and then a gap this big in between the veins, and then like there's no way to do it. So I just did the best I could, and that was clearly not like good enough. So we ended up having to go from the back, pull out the old cage from the back, pull on the nerve root like really a lot, and put a more reasonable size cage in there, and like double up the iliac screws and all that kind of thing. Thanks. Yeah, I was the junior partner here. So that's how I got this one.
Thanks, John Francis.
No, it is not John Francis. No, but he helped me he helped me pull out that cage from the back and put that big thing in. I had to get my big girl pants on for that one. But anyway, the only reason I keep that case in here is just to sort of illustrate that Alift approach, particularly in chronic discitis, is like it's a pitfall. Like I definitely don't do not recommend. 0 out of 10. Does not seem to work. So I'll just skip forward a little bit. So we do a spine ID clinic. This is my partner in spine ID clinic. We really try to manage these patients really intensely and you know, really try to meet those patients where they are. And then I can do 2 more cases if we have time, or if we don't, then I'll skip to the end. What do you think?
Do you want to do, this is the intradural one?
Yes.
Yeah, let's do one intradural one if you don't mind.
Okay, yeah. So I only bring this up because these are really hard and I don't really know what the answer is. We've had about like 5 to 7 of these in the past year, always drug users. So this is a 36-year-old guy with IV drug use. He presented with pain and fevers, really seems like infection. His white count was 23. And this is actually managed by one of my private practice partners in a community hospital setting. And so they looked at this and, you know, not unreasonably thought this was a ventral abscess, like ones that we've looked at earlier today. Got in there, did a really extensive lammy, like T10 down to L5. That was sort of what they had done, and didn't find anything. They couldn't find anything ventrally. And so they, correctly decided that it must be a intradural. And so they got this post-op MRI, showed sort of like this post-op fluid collection, really wide decompression. And this stuff looks exactly like it did before. And so then they went and re-explored, did an intradural exploration, and honestly, like could not access this at all. Like there was no, according to their op note, like no way to access that. The roots were all kind of just like socked around it. And, you don't want to go through something to get that. So took some cultures, all cultures were negative. And this guy ended up, basically just closing up after that, was treated with broad spectrum antibiotics because they had no cultures, but like a clear, infectious picture. And clinically he seemed to improve. And then he comes back to my clinic a year after this. He comes to my clinic with upper motor neuron signs. And then he has this. And you can see that this stuff down below is like pretty much resolved. But he has this sort of stuff anterior, again, ventral in the thoracic cord. So just curious what people would do on that one.
Yeah, this is going to be a tough one, but I think if you feel that there's a compressive intradural component, I think you have to explore that. I think I would explore that.
Yeah, so that's what I did. I did an osteoplastic laminectomy and tried to resect that stuff. And, I feel like when you get in there and do that, it always is like less than you think you're going to find. But we took some, it was like thickened arachnoid, took some cultures, sent some of the sort of fibrous scar material for path. Again, all cultures were negative. We sent path for like genetic analysis at UCSF, and a fungitel. Consider that it might actually be an inflammatory reaction to an additive in the stuff that he was injecting rather than infection. So then we tried to enroll him in the NIH study with that, but he wouldn't go. And so ultimately we didn't have any kind of resolution for this guy. But these intradural, presumably infections are sort of on the rise here, and we can never get like any kind of path on them. So it's just really unsatisfying treating, and they come back. So they're crazy. So there's that one. And then I'll just briefly, because I haven't done this case yet, really interested in what you think. This is a ESRD with renal osteodystrophy. 2 years ago had this. My partner did this and then gave her to me. And so now she comes back completely wallowed out all of her posterior hardware. Okay. This is what she looks like on FlexX's, and she's asking me to take her hardware out because it hurts her. What do y'all think?
I think she's right. You have to take out all of her hardware. Problem is you're going to put a lot more hardware back. So that's the only thing.
How high would you go then? What would you do for renal osteodystrophy?
Yeah, if the C1 lateral masses looked okay, I'd probably do like a C1 to T2 or a C1 to T4. If I wasn't happy with the point of fixation, I have no problem going up to the occiput. I know it scares a lot of people. I do not have an issue anchoring to the occiput, but probably C1 with maybe translaminar screws at C2 if the pars and pedicles are out. But she needs a long construct and a revision front back.
What biologic would you use for this?
Yeah, I'm pretty consistent with my infections. I don't use BMP. I rarely use any autograft. I just put a lot of DBM, a lot of allograft, and probably put her in a collar for quite some time.
Yeah, I can tell you she's not going to let me put anything back in, and she probably won't come back for me to operate on her. But that is definitely a dilemma. So thanks for looking at all those cases. I definitely think that PUS is really fun. You can help people. You can do really big surgeries that are pretty satisfying. You can do really small surgeries that are pretty satisfying. And patients are really grateful because they will never forget how sick they are and how much you helped them. So it can be really rewarding, especially the multidisciplinary component. And I'll just leave you with a parting thought from one of my mentors, John France. You can see him here doing one of his favorite activities. He says that no matter who you are and what you do, if you are a spine surgeon, you're going to see trauma and you're going to see lots of infection. And so you better, just learn to like it, and that make you much happier. So thanks for listening, though. I appreciate the attention.
That's awesome. That's a great quote.
Yeah.
Thank you so much, Cara. And Nader, did you have a follow-up thought? And
excellent presentation, Cara. That's I learned a lot actually, and God bless you for taking care of these patients.
It's so fun. I love it. It's so fun.
That's great. And there's a lot of it, spinal biomechanics goes into it, multidisciplinary treatment approaches goes into this. Key is understanding biomechanics too, and when to operate, when not to operate. That's still, more art than a science, to be honest, at this stage, given the level of evidence that we lack. But if you want to err on being aggressive, we commit errors of commission as neurosurgeons, so we should always remember that. You don't want to sit on someone and then the next day you're making rounds and they're going from 5 to 2, or paraplegias under your watch, which can happen certainly. So if you're not sure, operate on them.
Yep. Absolutely. Thank you guys
Solid,
again.
good advice. Great. Well, thanks so much. We went a little bit over, but again, great cases. And this is such a, like Dr. Sedney said, this is just such a common entity that we all see. We can never really have enough experience with this. We can never see enough cases because they come in so many different sizes and shapes and colors. But it's just a wonderful session. Thank you so much, Cara, on behalf of everyone, and hope to bring you back yet again in the near future. And have a great night, everybody. Thank you.
Thank you.